Thank you very much, and thank you for having me today. My name's Pritchard. I am a consultant anaesthetist and working in Buckinghamshire Healthcare, as you've already heard. I've been the pre-assessment lead there for as long as I've started as a consultant, which is probably about 12, 13 or so years. And I'm also part of the digital team as well, working in Buckinghamshire. What I want to talk to you today is about the surgical pathway. And we know there's a problem. It's in the news. It's talked about, the waiting list. It's now over 7 million, 7.5 million, I believe, patients. It's escalating rapidly. We all know there's a big problem with surgical waiting lists. But what we're not talking about, what I never see in the news, is this. These statistics. Now, hands up if you know that 1 in 7 patients regret having their surgical procedure. Not a single person. Why is this not in the news? This is 1 million patients coming for surgery on those waiting lists. This is happening in your trusts where you're working right now. On top of those 1 million patients who regret having surgery, 10 to 15% of operations have complications, and up to 80% of these complications can be prevented. That's another 1 million patients are having complications which can potentially be prevented. This is 2 million patients of those 7 million that are in trouble, and we're not talking about it. Why aren't we talking about it? So in Buckinghamshire, we've been really lucky that our GPs have connected all of their GP data. We've got a great digital team across Bob, across our ICS, and with the help of GraphNet Health, we have been able to attach all of our GP records to all of our waiting lists. So we have our GP data on every single 43,000 patients in Buckinghamshire who are on the admitted and the non-admitted pathways. So as you can see here, this is one of our first dashboards that we built about 18 months ago now. And we've got 6,000 patients waiting for surgery. We've still got 6,000 patients waiting for surgery. But look at the patients. However you look at these patients, they're in trouble. They are sick people. If you look at their frailty counts, 13, 14%, can you read that? Have got 10 comorbidities. If you look at the John Hopkins long-term condition counts, 14% have got more than 10 comorbidities. And if you look at the QOFs, where the GPs, document the comorbidities, it's exactly the same. These patients on our waiting list are really sick people. They are not young and fit, and they may not be benefiting from surgery. Why aren't we talking about this? So, if you're working on the surgical pathway, in the last 10 years, you've also seen an explosion called pre-op assessment that never used to exist. What is it? Is anyone working on the surgical pathway? Yeah, one person. So there's been a massive explosion in pre-op assessment. So there have been huge numbers of guidelines coming through. The charities have been involved, and the Royal Colleges have been involved. We know diabetics get 20% more complications. So hang on, guys, we've got to optimise our diabetic patients. They need to be really well controlled, otherwise they get complications. Absolutely right. The sleep clinics. Do you know how much undiagnosed sleep apnea there is in our population? As our populations are getting heavier, there is a lot. And they come to harm after surgery because they're dropping their oxygen saturations. They need your remote monitoring. So we need to do now nutrition screening, screen for frailty. These patients are coming to harm. Look at dementia, it's really undiagnosed. That gets worse. The trajectory of the dementia is accelerated after a surgical insult. Do patients know that? Do you know that? You're looking after these patients. And we need to get people up and about after surgery really quickly. So we're having to do more and more. And everybody knows it. It's not rocket science. So NICE knows this. We've now got NICE guidelines to make sure that patients are not anemic when they're coming for surgery. It's monitored by Model Hospital. These are our Model Hospital data. The charities know this. This is the Parkinson's charity. Have you read their recent report, Get It on Time? How horrific is it that they're saying how dangerous it is that Parkinson patients, yes, coming into surgery, they're not getting their meds, they're coming to harm. private companies know this. They are providing, and I may say absolutely fantastic services and apps, and there's a multitude of them. And of course, it's all because we haven't got that public health, we haven't got that conversation in society saying, you need to get fit for surgery, guys. Hello. You're not going to do very well if you don't have that cardiorespiratory reserve. You would never dream of running a marathon without any training. So why should we dream of proceeding to a major surgical insult without training? You've got to be fit to get through this. You've got to be fit to survive. You've got to be even fitter to survive a complication in intensive care. And private companies know this, patients know this. If you have a chance to talk to them, if they get the right information in a way that they can understand, which takes time to talk about the 20 comorbidities they have and how that might be destabilised having surgery. And actually, if their dementia gets worse, they won't be able to live at home anymore. They'll be in a nursing home. So maybe their hernia that wasn't causing many problems isn't actually worth having. So NHS England know this, and they've provided some very helpful guidelines recently, which we're very grateful for. But this is, everyone knows this data. But why is there conflict? We work in the surgical pathway, and we're forever being told we're a bottleneck in the surgical pathway. We're a bottleneck. Breaching. Patients are breaching. Everyone's nodding. Patients are breaching. The hospital's going to be fined. There should not be conflict. We know what the right thing to do is here. Why is it so difficult to do the right thing? So I'm going to give you an example here. This is what's happening around the country for our long waiters. So they see their GP, the GP refers them up to surgery, surgical outpatients, they may see the surgeon remotely, 10 minutes max, put on a waiting list, no time for discussion, GP doesn't know. They're in the community for 18 months, no information, don't know how to get themselves fit, don't realise the importance of nodding heads of how to get themselves fit. They're going to see the GP in that time, so I'll show you that data in a minute. They're going to see their GP. They may or may not have their long-term conditions monitored by their long-term condition teams or the GPs. And then 18 months down the line, suddenly somebody says, you're breaching, we better put you on a list. And pre-op get 2 weeks. And that might be fine when your patients are young and fit and they don't have comorbidities and they can survive surgery. And they do well, and a lot of patients do need their operations. And that might be fine if you've got 1 or 2 comorbidities and your diabetes is well controlled and your blood pressure is well controlled, and that's okay, you're going to get onto a list quickly and not come to harm. But that's not okay for your high-risk complex patients. So if we're lucky, surgery then gets cancelled maybe on the morning. Patients, are angry, quite rightly so. This is a terrible, terrible patient experience for our most high-risk and vulnerable patients. This is happening every day, everywhere, in every trust. And then theatre lists are going empty. The cost of those theatre lists going empty. So, question, do you know who your high-risk patients are on your surgical lists? And why haven't we got pathways to support our highest, most vulnerable patients? So when we first started out, we had a very friendly GP. We've still got very friendly GPs, actually, but they did some audits for us, looking at how many times patients go to see their GPs while they're waiting for surgery, a lot. And we looked at whether their GP records were updated with their blood pressure and the diabetes, and it was none, none, none. Shared decision-making conversations, none, none, none. We said to the GPs, why? You're seeing them on average 7 times in those 18 months. And the answer, they didn't know the patients were on the waiting lists. There's nothing on System 1 or EMIS just to alert the GPs. Simple things can solve these problems really easily. These are missed opportunities. We don't need to ask the GPs to do extra work. These are just missed opportunities. Patients are coming into A&E having heart attacks, strokes. We don't know about them, and then we're putting them on lists. So it's all about data, is what we did. We had our GP data. We were also used to the operations team having hold of the PTLs, the lists, and I'd never seen the PTL until about a year ago. I've been working in this trust for how long did I say? 12, 13 years. So we got hold of the PTL lists and we attached all the GP records to the lists, and suddenly we had some idea about how to plan services, what we need to optimise these patients, and actually suddenly we could talk to operations and give them the information they need to make better decisions about who's going on the lists. This was a reminder for me to not forget surgeons. Do I have any surgeons in the room? No. So a time of surgery is a really powerful motivating factor for patients to change any lifestyle issues, take responsibility for their health, get fit, lose weight, all those really hard but very important things when you're coming up for surgery. And it's especially powerful when the surgeon tells the patient to get fit, lose weight, sort your diabetes out, and then we can operate. So we've changed our waiting list cards so that this is mandated. Surgeons now need to think about how frail patients are, what prehabilitation is needed, and whether to send them in early, their high-risk patients, to anaesthetic clinics, because we can't get patients fit quickly when they're complex and high risk. So this is our one of the dashboards we've built for our operations teams. So our operations team said to us, we need to fill lists, and we've got last-minute slots, and we're under pressure. They didn't know who their high-risk patients were. So we built a dashboard with all of the PTL information they need. I'm going to keep an eye on time, I've got to speed up. On the waiting list, which surgeon, which operation, blah, blah, blah. And we coded all of the comorbidities in the GP's record so that if you've got no comorbidities, you're fit and well, you're a golden patient, you can get onto a list at last minute. You don't need a pre-assessment. You know, operation teams are really happy. Our green patients, they've got diabetes or blood pressure problems, but there is evidence in their GP record that we have access to that it's well controlled. There shouldn't be a delay for surgery. They can get onto lists. They can be done in elective operating hubs. They can be done on Saturdays. They're unlikely to need intensive care beds. But red patients are a different matter, and these are the ones that account for those 2 million patients coming to harm. So these red patients, you know, one of these lives in a nursing home, has got 20 meds, 15 comorbidities, and has recently been in with uncontrolled epilepsy. We're not going to get them fit quickly for surgery. You can't put patients like that on lists on Saturday or in elective hubs without intensive care beds. And they may need some optimisation and support. If they do need and want their surgery, they may need some support to get themselves there safely. So there's a slow realisation that we really have to change the pathway for our high-risk patients so that we can bring people together. So we can filter by anything on the PTL with anything on our GP records on our dashboards. So we've now got money from public health. We're working cross specialities, and public health have given us some money so that we can see all our smokers, we can think about health coaches, we know where they are, we know how deprived they are, what areas, what we need to do to give them the right advice to get them ready for surgery. Similarly, with the anemia, we know how many IV iron infusions we're likely to need so we can staff our clinics. We know how many high-risk patients there are on our waiting list, 20% of our waiting lists, and we know how many low-risk patients, 10%. I mean, this is a complete turnaround from 10 years ago. The demographics have changed. 10% of patients are low-risk ASA1 nowadays. When I started, it was 70. So we can plan our service. I think if you don't have this level of detail about your population, you won't spend the resources that you have wisely. We got it wrong. So, yeah, I can tell you about that another time. And we're a customer of Synopsys. It's been absolutely great. Deployed it and use it. What's interesting has been the most, obviously digital transformation doesn't change pathways and processes. If you've got a problem with your pathway and process, you still have a problem with your pathway and process. What's been great is that everybody used to complain, we don't know what's happening with this patient, you know, where are they, why can't we list them? Everyone can now see. So we don't have those questions, those chasing emails. Have a look on Synopsys, guys. We're waiting for an echo. We're waiting for sleep studies. You can't book this patient without an intensive care bed. It's all there. It's been really helpful. Even the surgeons use it. And it just stops those high-risk patients being dated for surgery before they're properly optimised. So it's a sort of horrifying slide, isn't it? Why aren't we talking about this? I'm going to leave you with this slide. Thank you.